Well, welcome, folks. I'm going to get us started because we want to tell the story about the Great Lakes Practice Transformation Network, which is a story about hero versus villain. It starts with the American dystopia that is the healthcare system today. This dysfunctional system consumes a quarter of our US gross domestic product, but delivers some of the worst healthcare among wealthy nations. The dysfunction permeates throughout the system, owing in part to the relentless pursuit of profit, but also because it's led by a faceless, often top-down management in which providers feel disenfranchised, hurt by token attempts to curry their favor. And what they see is really just promotion lies on billboards when they drive to work that say things like, "We appreciate our healthcare heroes, but don't really give the healthcare heroes the resources they need to affect change." Leadership usually entails the reactionary measures of sending an email with a bunch of attachments and links to policies written in legalese with thinly veiled punitive measures, and often linking to undecipherable appendices, policies written by lawyers. The mandates are made worse by some flowery introduction that this is about improving the patient experience. And simply stated, the American healthcare system is governed right now more by blame agents than change agents. Wow. This story is no political or cultural phantasm that we're making up. The dehumanizing effect extends out into the community. It infiltrates through the employees of the healthcare system, ranging from chiefs of services to charge nurses, to triage nurses, to even the people who answer the telephone. Most of us have experienced this insincerity. If you're over 50, I'm almost guarantee you have. Imagine the story of a 55-year-old male trying to schedule his colonoscopy. This is a make-believe conversation. It goes like this, though. Ring. Welcome to Mega Healthcare, where the difference is we care for you. If you know your party's extension, please dial it now. Otherwise, please listen to our menu of options. Beep, boop. You have reached MHC scheduling. Please stay on the line and our next representative will be right with you. Because MHC cares so much, please stay on the line for a 1-minute survey when you're done. Tick. Tock. 15 minutes later. MCH scheduling, may I help you? Yeah, I'm calling to schedule my colonoscopy. Sir, may I have your name and date of birth and insurance policy number? Well, I already put it in, but this is Jeff Kline and my birth date is 9364 and my ID is 101-6699-8800. Sir, who is your carrier? My carrier? Your insurance policy. Oh, it's MHC's HMO plan. What is your plan type? My plan type? Yes. Is it HMO in-network, HMO out-of-network, HMO PPO, HMO ACO? HMO, I don't know. Sir, we have to have your plan type and your group ID number and your BIN number, your PCN, RX group. This should all be on your card. Well, I never got a card. Sir, you'll have to contact your employer. Well, MHC is my employer. All right, I'll give you a case number, and when you call back, you can update your appointment. And also, you'll need your pre-authorization for your propofol. My what? Your pre-authorization to pay for your anesthetic for your procedure. Where do I get that? You'll have to contact your doctor, sir. What if I don't get it? Sir, I'm not a doctor. It'll be up to your doctors who do the procedure. I suppose they'll do it without it. What, you mean they'll do an awake colonoscopy? Geez, it wouldn't be much different than this phone call. Sir, I'm not a doctor. Well, I guess we're done here. Is there anything else I can help you with? Nope. Would you please stay on the line to take our survey to tell us how awesome we are? Yeah, sure, if one of the responses has the option F you. Slide, please. Obviously, this is hyperbolic satire, but the essence of this imaginary exchange has been felt by many of us. Navigating the healthcare system is like descending through Dante's circles of hell. And for relatively healthy people, the hell is only the first 7 circles, which is pretty bad. Slide, please. But for people with chronic disease, they descend deeper into the 8th circle. And it's worse there. And for those with progressive chronic diseases like Alzheimer's or cancer, they and their families end up in the 9th circle. Next slide, please. It's no wonder why healthy people avoid vaccinations or are willing to be vulnerable to mental health screening, or persons with chronic disease like diabetes avoid monitoring, like for the hemoglobin A1C. Within that context, in Middle America, the transformation network had to engage a plurality of providers in multiple hospitals, multiple systems, multiple networks, and all these people wanted to do better, but they felt like they were part of a machine that was constantly working against doing things right, even when they wanted to do the right thing. And what follows is an imaginary game of 3 possible journeys, each with 3 different possible outcomes. Let's see what works and what doesn't.
The Great Lakes Practice Transformation Network set some lofty goals. They wanted to provide technical assistance for over 11,000 clinicians over a period of 4 years, improve health outcomes for millions, reduce 410,000 unnecessary hospitalizations among 5 million patients, generate $1 to $4 billion in cost savings to the federal government over a period of 4 years, sustain efficient care delivery by reducing unnecessary procedures, build evidence base on practice transformation so that effective solutions can be scaled. So overall, it's about creating a healthier community. Many clinicians want to help their patients, but resources, including human resources, are limited, and it's very difficult to stay motivated. Next slide. So the goals that they chose were improving diabetes control, influenza vaccination rates, and depression screening. Depression is a serious mental illness associated with high rates of chronic disease, increased healthcare utilization, and impaired functioning. Data indicates as the severity of depression symptoms increase, so does the difficulty for work, home, and/or social activities related to depressive symptoms. In 2009, an estimated $22.8 billion was spent on depression treatment, with lost productivity costs an additional $23 billion. Routine screening for mental health problems as part of a primary care for both children and adults, making an important contribution to the quality domain of community and population health. Next slide.
Wow, Michelle, those are some really lofty goals that they had. And I'm sure the cohort is probably asking themselves, how in the holy schmokies do we go from JK's Dante Inferno story to accomplishing the goals of the Great Lakes Practice Transformation Network that you just reviewed? Well, to answer this, we're going to play a game. And this game is called Choose Your Own Adventure, and it's in search of Healthcare 2.0. And if you don't know what Choose Your Own Adventure books were like, basically you get to make choices, flip to different pages based on those choices, and that basically determines the plot outcome. And here is an example of how the game will work. I'm going to choose a door. Right now, I'm going to choose the white door, or the brown door on the White House. And I can choose to knock or ring the bell. And I'm just going to knock. And actually find out that no one's home. But that's okay. We're going to do something similar with this version of Choose Your Own Adventure, we want to pursue the goal of increasing depression screenings. And we're going to select random people from the audience to participate. So Carmen, you're going to be the top-down administrator role. This could be a CMO role or a CQO role. And so Carmen, you have some choices to make. If you want to generate demand for increasing depression screenings, and you want the best way to engage your staff to get their buy-in, to get them excited, to get top engagement, are you going to bribe them with pizza or bribe them with chips and salsa?
Chips and salsa, pre-COVID.
All right. Well, unfortunately, no crushed tomato and garlic is going to help in this scenario. And actually, it usually turns out to be some sort of potluck chips and salsa, and it just doesn't work out for anyone. So too often we try to establish change before sufficient demand for that change is established. And so Carmen, if you would have known about embedded biases, like the ones on the screen, no amount of break room pizza or potluck chips and salsa is going to help you. You need to do the research, find out who the best messenger might be, understand the default choices people might have, maybe even prime them effectively before delivering the message, and maybe while you're delivering the message, set social commitments. And that way there will be a greater chance at success for the change. All right, we're back. So Carmen, you're now sending an important message about your goal of increasing depression screening. You have another choice to make. Are you going to send an email with 14 attachments, or are you going to send a 14-page email with one attachment? In both cases, you make assumptions that everyone is going to read and understand your message.
I choose none of the above, please. Let's go with option number one, the blue one, 14 attachments.
Well, remember, the appropriate documentation standards that we gave you are on page 10 of the attachment that we sent back in March. You should have had that committed to memory when you did your latest dictation.
Exactly. Neither of those choices were great. And actually, both of them are depersonalized and don't take advantage of what we know about behavior economics, humans, or agile diffusion. And we spend most of our time in a reactive state called System 1, to which many of us are unaware. And success hinges on understanding how humans receive messages and from whom. So give people space to think, wait for 15 seconds before responding. Humans have a terrible hippocampus. So the minimum goal as an administrator, Carmen, should be to start gathering up the mastery of great storytelling, nudging, agile mindset, building your tools, processes, and using agile science to become that change conductor and change agent. And when you become a storyteller, you have massive power and you're an influencer. All right, one last item for you, Carmen. A quality issue has actually come up and needs to be addressed in the middle of all of your generating demand. And you need to set up, you have another choice to make actually. So you can either cram it down physicians' throats that this has to be fixed right now because the hospital is losing money, or you can add a best practice alert.
Wow, this is so
Let's
true
go with
though.
cram it down. I know, I was gonna say,
So
I go with
true.
cram it down your throat because it's less painful than the alerts all the time.
You got to pick one.
Or number one, cram it down in throats because it's not as persistently painful as the emergency alerts time.
All right, well, that's also not a great choice. And the conditional interactions within the network, you can see the title here. It's understanding the human complex adaptive network, and that it comes down to humans. Holy schmokies. When we think of this diagram, we think it might need a little bit of updating, because in one of our residencies, they talked about sitting down with a cup of coffee, maybe 10,000 coffees. And when you share a cup of coffee with someone, the communication and information exchange and trust increases. It all comes down to communication between nodes. Maybe the guards can come down and you can have time and space to talk. And the same thing happens around a water cooler, or maybe even around a fire pit. And it all goes back to storytelling, bringing back the human aspect and humanizing the system that we're all in. All right, now we're going to pick on someone else from the audience. Thank you, Carmen, for your participation. We're going to go with Virgil. Virgil, you're going to be the frontline clinician, and you've got some choices to make. So when you want to create change as a physician, maybe you really want to buy in to help your CMO, Carmen. Are you going to continue to do the same thing over and over, like fighting fires in the whirlwind? Or are you going to choose the default or status quo?
They seem the same. They seem to be exactly the same. So,
They
but
could
pick
be.
one anyway.
Yep.
Okay. The defaults.
All right, the default or status quo. There is a better option out there. And realizing it doesn't have to be this way. You can leverage the knowledge, fundamental knowledge around behavioral economics, the agile mindset, and agile implementation. And understanding that it's okay if something fails, having a termination plan, not being married to one solution. But what is agile implementation anyway? My button's broken, sorry. All right, we're gonna go back up to the beginning of the game and we're gonna go with the change agent. Thank you, Virgil, for your participation. All right, Lauren, you're going to be the change agent. Okay, so as a change agent, you have an action to choose. You're at Turkey Creek. You can choose to walk by yourself or you can choose to walk with Randy. Which one do you choose? Hint, it's walking with Randy.
All right, let's go ahead and walk with Randy.
Excellent choice. All right, and agile implementation, it really does get down to harvesting demand, opportunity, and preparedness. Malaz didn't have to go on that walk in Turkey Creek, but he did. He took a chance. And it was the right time. The federal government had money available, and it was the right partnership. Randy, he was into lean. Malaz was into this new thing called agile implementation and innovation. There was the right mindset. Both of them wanted to make an impact on public health and people's lives, and there was the right demand. So the Great Lakes Practice Transformation Network was able to translate local context, local sensitivity. There was no one size fits all. They empowered each node. They had operational teams in each state distributing lessons across the network. They were able to adjust the plan in local and agile ways using feedback loops. And because they understood the network, they were able to diffuse the innovation out to the rest of the network, ultimately improving important public health initiatives like depression screening.
So here are the successes from the health outcomes through practice transformation with Great Lakes Practice Transformation Network. Clinicians were given toolkits, but also what they were given were like human resources, such as advisors, and then transparent data monitoring, and then regular check-in with people, and as well as like IT resources. The outcome was incredible. The diabetes, as far as like patients that were affected with diabetes, 61,468 patients were benefited from this. Depression screening and follow-up, over 300,000 people were affected, and with vaccinations, they improved the health of 325,000 patients.
Just for context, 320,000, that's like the size of Cincinnati. That's a lot of people.
I think what is really amazing is when you look at the national aims and then what the network aims were, they wanted to at least enroll over 11,000 clinicians, but actually they enrolled over 13,725 clinicians. They had originally budgeted a little over 4,000 for just 1,100 clinicians. So that took it a little bit over 3,000 for the 1,300 that they enrolled. When you look at their results with quality measure improvements, clinical quality measure improvements, they almost doubled it, and then had an amazing, instead of 850,000, they went over $1 billion as far as in savings. And reductions in the hospital, they took it up to 62,000. Those are amazing results.
And thus we have seen that using an agile science approach, that big changes can happen within a system that is currently and has been often in many places dystopic. The first principle is that it can't be done with an email with a very long attachment and lots of links to something that no one understands. It's an ongoing process that changes the basic way that people think and interact, which is their culture. It's often said, culture eats. I'm blanking on it. Culture eats. Strategy for breakfast, which requires making relationships, and those can be done over coffee, or between friends, or at a fireplace. And this leads to humanization of a whole system that is currently dehumanizing. And it must be done with unremitting drive and attention to detail. And the details are about the people or the nodes in the network that interact. And it can't be done all at once. There's not a bulldozer approach. It has to be started with pilot studies, which are sprints that then lead to information that gives feedback from sensors that then is retested and revised again. And it's often said that luck is the intersection of opportunity and preparation. So no agile network is executed without a great deal of thought, preparation, and knowing the target audience. The impact is shown in the graph on the right that indicates an increase in depression screening from really almost single-digit numbers up until something the size of the city of Cincinnati. And somewhere within 320,000 persons, there were many people who were mired in depression who could not adhere to their medical care, could not make their appointments because of their depression. And there were others that would progress with their depression to suicidal thoughts, suicidal actions, and suicide itself. And clearly this prevented the permanent solution to a temporary problem for at least one, if not many persons, and leading to the ultimate slide. Whoever saves one life saves the world entire.
Wow. Wow. Wow.